Shall I start, ma'am?
For sure, for sure.
Yeah, sure. So good evening, doctor. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of today's webinar is managing poor ovarian reserve. And the guest speaker is Dr. Maria Jos Mendiola, madam, from Peru. So it's my honor to introduce ma'am. And in terms of education, madam did her master's degree in human genetics, Saitano Heredia University, master degree in science communication, Valencia University, and MD from San Martin de Porres University, 2011. Bachelor degree of Science in San Martin de Porres University. In terms of professional experience, madam is the consultant physician at Monterrico Clinic, clinical trial researcher, Genob SA, and attending physician in Conservic Clinic. And apart from that, madam has many awards to her credit. She is the Young Scientist Award winner 2020 for Best Scientific Publication and 28 World Congress on Controversy in obstetrics, gynecology, and infertility, COGI Germany, 2020. She has scientific poster selected at the 37th virtual annual meeting of the European Society of Human Reproduction and Embryology. Madam has many publications in reproductive genetics as a principal investigator at second IVF Worldwide Congress, selected as the 36th virtual annual meeting of ESHRE as one of the 10 human of ESHRE professionals. First place in PEC online, best grade in reproductive medicine internship, and first place in medical residency in 2013. So with this short introduction, I request madam to take over the session, and meanwhile I request all the participants for their active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion with this topic with ma'am. So thank you very much, madam, and over to you.
Thanks so much. I'm going to share my presentation. Okay. Good night to everyone. Good morning from Lima, Peru. It's a pleasure to share with you this webinar, and it's a pleasure for me to share this delightful time and this delightful evening. I'm Maria Jose Mendiola. I know that my name is a little bit tricky to pronounce and to spell, but you can recall me as Maria. I'm gynecologist, specialist in reproductive medicine and reproductive genetics. I have been an ESHRE Young Ambassador in the last ESHRE meeting, and for me it's a pleasure to share all the knowledge that I have been reviewing about pure ovarian response. First, it is important for me to start that I have no current or future conflicts of interest regarding this presentation or regarding all the topics that we're going to review through Shield. This is the agenda that we're going to review in this lecture. First, it's important to start about the definitions. Then we have to know and review something about the epidemiology, then the etiopathogenesis, diagnosis, treatment, and last but not least, it is important to review the conclusions that we should know regarding this topic. Well, if we want to know, if we want to review some definitions about poor ovarian response, it first started in 1983. This definition, when all the IVF treatments and all these treatments were spreading throughout the world. But then we needed to rule out some criteria to assess all our patients that could have poor response. So in 2011, it started the Bologna criteria that we're going to review. Just 5 years ago, we had the Poseidon criteria that I think that it has been a breaking point in our daily practice. So first, we have to know some definitions that have been spread by ESHRE. It is important, the Bologna criteria that started in 2011. We have to know that there are 3 criteria, but we must meet 2 of the 3 criteria to define a patient as poor ovarian reserve. First, if we have a patient that is after 40 years old, we should know that this is a factor that could meet a criteria of the Bologna criteria. If this patient have gone ovarian stimulation and she had a poor response, how can we define a poor response? That we had less than 3 oocytes that had been retrieved. So it's a poor ovarian response, a poor prior response. If this patient had value of AMH under 1.1 nanograms, it is defined as a poor ovarian response. Also, it is important to assess sonography in our patients. How can we rule out this? For example, when we assess our patients, first, we should know the antral follicle count. And if the antral follicle count is less than 5 or 7 follicles, we should be warned that this patient could have a poor ovarian response. If this patient meet 2 of the 3 criteria, so according to the Bologna criteria, this patient has probably poor ovarian response. So what is the problem with the Bologna criteria? Well, the Bologna criteria, you should know that is very is very narrow. So it has been another criteria that should be assessed according to this topic. For example, if our patient has had 2 episodes of low response after maximal stimulation, so it is important that she could have a poor ovarian response. Either she has below under 40 years, either she has a normal ovarian reserve test, but if the patient has had 2 episodes of low response after maximal stimulation, even though she's young, even though she has a normal ovarian reserve test, according to DHEA, she has a poor ovarian response. So that is important to rule out in our patients. So this is a slide that we could share about regarding the Poseidon criteria that was published in 2016 by the Poseidon group. So this group was important because we should know that all the data regarding Bologna criteria was not so specified. So there was, I think that there was an empty room in this space. So the Poseidon criteria helped us to assess some strategies in our patients. So the Poseidon criteria is the patient-oriented strategies encompassing individualized OSIC number. So I'm going to translate this, but this is, it is according to the age of the patient, to the antral follicle count, and according to the value of AMH. So we could have a patient with a normal ovarian reserve, and we could have a patient that we know prior the stimulation that she has a poor ovarian reserves. So we have the group 1, the group 2, the group 3, and the group 4. The group 1 and the group 2 are patients that according to the antral follicle count, according to the AMH, according to the ovarian reserve test, they have a normal ovarian reserve test. But in the group 1, they are women under 35 years old. And in the other hand, group 2 are women that are below or after 35 years old. But what happened? When we started the stimulation, the ovarian stimulation, we could not retrieve an adequate number of oocytes. So the response regarding the stimulation was not was not expected, even though we have some exams like sonography or laboratory exams that were pretty good, but the results were not reassuring for us. So that wasn't a strategy that we could improve in those patients. On the other hand, we have the patients that prior to stimulation, we know that they have a poor ovarian reserve, that they could be young women um, under 35 years old, or women that are more than 35 years old. So the stimulation is expected. They have a poor ovarian reserve, and the oocytes that are retrieved are under 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 5 oocytes, more or less. So I think that this rules out so many outcomes, many scenarios. For example, in the group 1, in the group 2, I think that are very challenging for us, for clinicians, for embryologists, because these results are not expected in our daily practice. Prior to stimulation, we were thinking that all the exams were pretty reassuring, but after the stimulation, all the results were not expected ones. So what happened to that? So we're going to assess these definitions. I think the positive groups give us some good scenarios to assess our patients and to treat our patients. So this is a good slide that was shared by Ferraretti at Human Reproduction about 10 years ago. We can see that in younger women have less cancellation rates, and even though they have less oocytes, and women after 35 years old, the cancellation rates are higher, even though they have more oocytes retrieved. So there is an impact on the age and the quality of the eggs. So some etiopathogenesis is important to review. It is important to assess that the follicular allocation according to the age of the patient. So even though we can compare many statistical models, we can see that every statistic model has the similar outcome, that women continue losing all the follicular allocation according to the age. So that is very important to assess and to explain to our patients. So what could happen to our patients that have a worse prognosis? What could happen to our patients that, for example, in the group 1 or 2 of Poseidon, that prior to the stimulation, we thought that it was going to be a good protocol, and after all the evaluation and all the protocol and all the IVF stimulation, the results were not the ones that had been expected. So it is thought that these patients could have some genetic polymorphisms of endogenous gonotropins or their AFSH receptors. So they have some polymorphisms in the AFSH receptors. That what is the outcome? They have a worse prognosis. These polymorphisms, serine 680ASN and tyrosine 307 alanine SS, are the polymorphisms that have the worst prognosis. So these women could take any advantage if we add to the stimulation an LH that is recombinant. So if we start a stimulation in these patients just with AFSH, they could not have any advantage of that. So because of these genetic polymorphisms, they could have obtained an advantage if we add a stimulation with LAH recombinant. So what can be another factor that can predict the outcomes that we can obtain in our patients? We should assess the ovarian reserve test, the AMH, the AFSH in the day 3, or the or a sonography to assess the antral follicle count. But we can know that all these ovarian reserve tests can predict their response regarding the stimulation, but any, there are any of these exams can predict pregnancy. So MNH and antral follicle count are the best predictors for ovarian response, but they are no the best predictors of pregnancy. So that is important to assess in our patient because there is a lack of precision regarding this test for sure. So this is a normogram that was presented a few years ago by Sukara regarding the possibility if we want to calculate the probability of a newborn according to number of oocytes and age. So if the patient is starting, even though she has less oocytes, the probability of a newborn is higher if we compare to a patient that is after 40 years old, for example. If we want to start a treatment, first we should know a protocol selection. For example, the protocol selection could be assessed regarding 4 topics. First, we should know the age of the patient. Second, we should estimate ovarian reserve, and the ovarian reserve should be estimated regarding the exams, the laboratory exams, regarding the antral follicle count, regarding the body weight. If the patient is overweight, it is a problem because we will need more medicine to obtain more oocytes. So that is important. If the patient has a high body weight, it's important that we should know that the medicine should be well assessed. First, it is important to assess all the response, the previous response that has got the patient. For example, if the patient has had this, for example, another IVF stimulation. If the stimulation was not good, we can improve some strategies. So it is important to assess that. But we should avoid poor response incidental in 1/3 of the patients. So it is important to assess what is the best starting dose for our patients, because if the starting dose is not right, 1/3 of the patients would have a poor response incidental. So for example, in my patient's overweight, if the patient is overweight, I should give to the patient high doses of gonotropins. So there is a key point that we should rule out, please. It is important to assess that multiple stimulation strategies and interventions, it has been up to 33 published, have been tried in the low responders. So without any of them having been shown to be clearly better and effective. So there is a great difficulty in evaluating interventions due to the heterogeneity of groups, frequently multiple interventions, and the number of cases. So that is important to highlight. So, according to several societies, as ESHRE or the Spanish Society of Fertility, it has been published many data, many consensus regarding stimulations in patients with a low response. So what is the recommendation? That there is no consensus regarding the best stimulation protocol in patients with a low response. So it is important to assess what is the treatment that we could be to patients that are going to start a treatment. For example, one strategy that we can assess in our patient is to start up a treatment. And how can we start up a treatment? For example, if we are going to start a pretreatment, we can start with estrogens. What is estrogens? It's used at a dose of 2 milligrams twice a day in the luteal phase, reducing the ovarian stimulation cycle, 5 to 7 days before the next menstrual period. It inhibits the FSH peak with a lower ovarian breaking than hormonal contraception, for examples. By getting a more synchronous follicular growth, there is a lower risk of cycle cancellation. There is a higher probability also of pregnancy per cycle started due to the lower rate of cancellation. We could start these estrogens, for example, Proinova, 2 milligrams twice a day in the luteal phase, so it could give us greater chances. But for example, I have reviewed other studies, and other studies have found no difference between the number of oocytes obtained on pregnancy rates in the general population. This strategy probably cannot be recommended to improve the effectiveness of the ovarian stimulation. Even during my daily practice, I use this inside patients to synchronize the follicles. I should rule out that this is a practice, a strategy, but regarding the data, regarding the evidence, it cannot be recommended to improve the effectiveness. Another strategy is to use a separate treatment of prior ovarian stimulation combined oral contraceptives. It inhibits FSH in the previous luteal phase, and they allow more follicle growth synchronous in ovarian stimulation. However, in some patients or with use prolonged, they can suppress ovarian function in the next cycle of stimulation, so its use is controversial. There are no differences that were found in true RCTs in terms of number of oocytes retrieved and pregnancy rates in low responders. The type of estrogen and progestin, dose, duration, interval between completion and onset of stimulation, and the type of gonotropins used in stimulation later are some variables that make it difficult to assess this strategy used frequently to program the start of the cycles. So what is the conclusion? That this strategy probably cannot be recommended to improve the effectiveness of the ovarian stimulation in poor ovarian response. So if we're going to start a treatment, we want quantity versus quality. This is a balance that we should assess. We have the agonist protocol and the antagonist protocol. The agonist protocol is a long protocol. We can obtain one more egg of oocyte. It has a lower cancellation rate. But if we use the antagonist, the cancellations will be equipped. For example, if we use a pretreatment in the previous site, for example, progesterones or contraceptive, just because it makes the follicles to be really similar. So for me, both strategies are recommended according to the evidence. So what protocols we can use in patients that has a low ovarian reserve? We can use clomiphene alone or in combination with gonotropins versus gonotropin stimulation alone. It is also recommended in patients with low response prediction, having the same safety and efficacy profile. We can use a gonotropin, but the dosage, it is according to the patient. For example, in general, the starting dose is, for example, 150 to 5 units of FSH in patients that has lower BMI under 30. With 75 could be 150. But if the patient is obese, it is suggested for sure to start with higher doses, even though the patient has a few follicles. But if she has obesity, you should start with 30 500 of units of FSH. So I should know that it is not recommended to use doses higher than 300 of FSH because it has been associated with a lower chance of the newborn. So up to 300 units, and if the patient is obese, we should give to her the higher doses. So what is another strategy? In these patients, would we use LH suppression? Well, we know that the progestogens are used to prevent the LH surge, and it is a novel protocol that omits the use of the analogs. So it will be very economic. So the use of this protocol is limited to cycles. Indeed, the embryos will not be transferred. For example, the endometrium will be inadequate. The implantation, the window implantation will not be adequate because of the exposure of the progesterone. So in these cases, we should vitrificate the oocytes or the embryos. The studies do not show differences in the number of oocytes retrieved or rates of liver rate. It is friendly. For sure, it is friendlier because we use oral tablets. It is flexible in terms of follicular development monitoring, and it's economic, as I have already mentioned. The regimen used in these cases in our center, for example, for the donors, it is medroxyprogesterone, 10 milligram every day orally. So what is the type of gonadotropin that we should use in this patient with low ovarian reserve, poor ovarian response? We should have 4 points that are the breaking points in our daily practice: the availability, the cost, the convenience, and the clinician preference. You should remember that there is no difference in efficacy between urinary and recombinant gonadotropins. So last but not least, we're going to know, even though we have the treatments, we have the protocols, we have us as our patient, we want to fight for our own eggs. So we should know what complementary treatments we have nowadays. We have the epidrostone, the DHEA, that is used before ovarian stimulation, is one of these interventions. It is an endogenous steroid. The mechanism of action is not fully elucidated. It has been shown that this oral administration increases the serum levels of insulin-like growth factors, which appears to have a positive effect on follicular development. The usual dose is 25 milligrams twice a day by mouth for 6, 8, or 12 weeks before start the ovarian stimulation. Due insufficient data on the duration and safety of administration, its use is not probably recommended for low responders. So that is the evidence. Then we have the testosterone that could be used transdermal with a dose between 10 milligrams to 12 milligrams of testosterone for 15 to 21 days prior to the start of the stimulation. So recently, studies suggest that it is only used in patients with who are carriers of some polymorphisms in the androgen receptor. So based on current evidence, testosterone used prior to the ovarian stimulation probably not recommended for low responders. Then we have the growth hormone that it also participates in oocyte maturation, but its data, all these results are very controversial because it seems not to have great benefit in low responders in older age, while in young women with cycles previous failure or low responses increases the number of oocytes and embryos and implantation and pregnancy rates. The doses are very variable, between 2 to 7.5 units each day, but the studies carried out are with few cases. So the determination of low responses, heterogeneous doses used are very heterogeneous. So we have no safety data regarding long-term. So it is considered that all the quality data is not sufficient to recommend its use. Then we have the coenzyme Q10, that one of the mechanisms in low responders is regarding oxidative stress and mitochondrial dysfunction. So we know that mitochondria are the most abundant organelles in all size and in the embryo in early stages. So if we have elevated reactive oxygen species levels in mitochondria, it contributes to its dysfunction and increased stress oxidative. So this coenzyme Q10 acts as an antioxidant by inhibiting lipid peroxidation and the DNA oxidation. So one of these times that I have been using in my practice is the effect of minocytol supplementation. It is regarding this data, we have some reassuring data, but we should continue review. We should perform RCTs. We have this original article just 2 years ago that was regarding the effect of minocytol supplementation on exit outcomes. So the outcome measures were the number of retrieved oocytes, embryo quality, ovarian stimulation, and the conclusion was that the treatment of poor responders with minocytol from 1 month before starting the exit cycle continue until the ovulation trigger can improve fertilization rate and embryo quality. So it is a vitamin that has a potential novel intervention in spontaneous ovulation restoration. It has been found to reduce androgen production in TECA cells by improving estrogenesis. And the supplementation has also shown to enhance the intracellular calcium oscillation in animal models. So it is very reassuring to review this data. So it has been studied in a case control group, the group A and the group B. One group received 4 grams of minocytol and the other group just folic acid. So we should know that the group A had better rates of good quality embryos and was statistically significant regarding the p-value. So there are other studies about minocytol reverse for fruit responders in other groups. So the conclusions were similar, that were statistical significance, that minocytol therapy in poor responders can increase the number of oocytes recovered in metaphase 2 and gonotropin ovarian sensitivity index. So we should improve this ovarian response and continue performing some studies. So the conclusions about this topic is that the management of the low responder patient is a current challenge in reproductive medicine. We should fight for some patients because we have another solutions, for example, assignation, but there are some patients that are very challenging for us, and we have some strategies to manage. We have prediction tools like the antral follicle count, the AMH levels that are reliable up to 80% for ovarian response to the simulations, but they are not predictive of pregnancy. That is so important to point out. They predict ovarian response, but they do not predict pregnancy. A Pretreatment or stimulation drug has not been identified to solve the loss response, just as there are no adjuvants or recommended strategy to increase the follicular endowment or follicular recruitment. Then we were going to finish that it is important to individualize the initial dose in ovarian stimulation in order to avoid a low accidental response based on antral follicle count, AMH, previous cycle stimulations, and could be genetic study of sample dimorphism if it is available in our practice. The choice of the protocol and the drugs is made on availability, convenience counts, and clinician preference. And last but not least, we can choose different strategies. We can cancellation of the cycle, we can accumulate oocytes, we can perform a duosity, we have the chance of doing an oocyte donation, but it is based on multiple circumstances. For example, if it is public or private center, the economic cost, the probability of success, and ideally should be agreed with the partner. So my passion for science can be summed up in this great phrase: if science does not communicate, it does not exist. This is my social media that I can share with you. Thanks so much. It's been a pleasure.
Yeah, thank you very much, madam, for this nice and informative presentation. And meanwhile, I request received few questions. So if you allow me, then we can discuss on that.
Okay, for sure.
Sure. So, ma'am, the first question is how does the stress or psychological parameters affect in the ovarian disease or ovarian disease, you can say?
Okay, so the stress can increase the cortisol level, but it has not affect the results. It has not affect or the results regarding the parameters like the follicle count and the age. So there is no evidence regarding the increase of stress and the impact in pregnancy.
And in case of, say, in case of PCOS or some other associated problem, if there is an infertility issue, and in case of POR also, so what will be the difference in the strategy for treatment in both the cases?
So it is important that we should not repeat all the protocol and all the strategies in all the patients. For example, in PCO patients, they have increased levels of androgenous. So these patients should benefit, for example, from myo-inositol. If these patients have some resistance regarding the insulin, we should correct this parameter, because if we do not correct this, all their outcomes will be so bad. And according to this, these patients benefit also if we stimulate with gonotropins that has just, for example, AFSH recombinant, because it helps them out to recruit a good number of quality eggs. But it is important to manage their weight and to manage the insulin to have good outcomes in these patients.
Yes, thank you. And in recent times, many research papers are coming that is showing that too much amount of DHEA can cause some problems. So, what is your findings? How long can it be prescribed for this induction?
Maximum 3 months. Maximum 3 months, I recommend the induction because it could cause some problems regarding the sexual differentiation. So I recommend no more than 3 months.
So thank you very much, madam. I could not find any other questions. So with your permission, we can close this session for today's. And thank you for
Thanks
your
so
valuable
much.
time. Thank you.
Have a nice,
Thank
have
you.
a nice night. Thanks.
Yes. Good day, ma'am.